Negative attribution bias is a problem that comes with brain injury for many individuals. With this bias, people interpret ambiguous behavior and information either negatively and/or harshly. Negative attribution bias with brain injury is a problem that stems from and is fueled by or made worse by other brain injury problems. This talk and the discussion that accompanies the presentation gets into plenty of details about the nature of this problem, what is thought to underlie it, and what new treatments are being developed for negative attribution bias. Dr. Dawn Neumann, she's an associate professor at Indiana University, and she's going to be speaking today about negative attribution bias. And I wrote this down. Negative attribution bias is when people interpret ambiguous behavior negatively and judge it in a way that it could be interpreted as hostile or just overall misinterpreted in a negative way. This may be linked with anger and aggression, and I think is very common with brain injury. I have this and have always had this. And there's another guy, Mark, who does these brain injury videos on Facebook. And the moment he explained it, I was like, oh, I have that. And then I explained it to my wife. She's like, oh, you have that. And then I was like, how many ways do I have this? And I didn't even know it was a thing. But once I realized it was a thing, it has helped me to frame it every time it happens to me. And I don't think I only have it with people. I think I have it with objects as well. So let's get started.
Yeah, absolutely.
Yeah.
Thanks for that introduction, and then kind of just bringing to awareness to the group what it is. I will go over it too, again, giving some examples.
Hard to put into words. Yeah.
But I do think a lot of people experience. Well, actually, I'll get into it in a second.
I'm just gonna add right here because with the last video, I'm recording these and I want to put them out. And the questions that we have really help to make the content more like, I don't know, just filtered into the everyday life of us. So I'm leaving the questions in, and
yeah, and I just want to add something silly, but I'm really happy to see the TBI support group sitting there also on this call.
Yeah. Hi.
Yeah, I noticed that too.
Hi, Ruth.
All
right.
Thank you for joining. Well, thank you everybody for joining, and thank you for having me back again. So I guess I didn't scare you off too badly the last time, and vice versa, right? But so today I'm talking about another area that is extremely that I'm extremely passionate about. And as Dan said, it's about negative attributions after brain injury, and I'll get into that in a little bit, explain a little bit more. But I do just want to start off acknowledging the funding agencies that have supported this research. So lots of thanks to NIDLR and to NIH for supporting the series of research studies that have gotten me to this point. Without it, could not have made all of the advancements that I have been able to make to date on this area. So I thought before I would jump too immediately into things that it would be helpful if we all are on the same page when it comes to a definition and differentiating what an emotion is versus a behavior versus what emotion regulation is. And so essentially, when we are talking about an emotion, it is a mental state that somebody has. It's a subjective experience that derives from situations that can either be external, so meaning something that's in our environment, like a noise or a person or an interaction with somebody else, or something internally, such as pain or an internal thought that we have that can trigger us to have an emotional response. And this subjective experience that embodies an emotion also not only includes our mental state, but it also includes the changes that happen within our body when we have an emotional response, or those changes in heart rate, perspiration, tension, etc., as well as our expressions of that emotions that we have, whether it be a smile or a scowl or crying, etc. So kind of emotion is embodying a bunch of things, and together it forms that subjective experience of the emotion. Versus a behavior is an action or a reaction that we have that is triggered by a combination of the emotions that we have, the thoughts that we have about a situation, and then those physical sensations. Behaviors include not just the like general reactions, but it also includes the expressions that we have, those affective expressions, so the smiling, the scowling, as well as things that we either do consciously or subconsciously to regulate our emotions, and regulating our behaviors. And so, and then when it comes to emotion regulation, these are strategies that either could be conscious or not in our conscious awareness that we use to modify our emotional response. So when we have emotional response, this is either something that is pleasant and we want more of, or to maintain it, or it's unpleasant and we want to minimize that or decrease it, so that our regulation is happening where we're either consciously or not consciously doing something to maintain, decrease, or increase that emotional response.
Two questions of clarification real quick.
Mhm.
So you include the thought in the behavior,
So
and,
it's mhm.
and you include the emotional regulation in the behavior?
No, a thought is more of what contributes to the behavior. A thought is kind of an internal situation that contributes, that is going to trigger a behavioral response. The emotion regulation, so when you talk about a strategy that you do, like you might practice mindfulness, yoga, listening to music, doing deep breathing, making a decision to problem solve, making a decision to walk out of the room, to take a nap. Those are like whatever, those can be emotion regulation strategies. Those are also behaviors.
May I ask another clarifying question,
Mhm.
Dr. Neumann?
Mhm.
Behavior, would that not also be triggered by instinctive response? And is that part of your definition by a different word? You know, like removing
Mhm.
your hand from a hot stove, for example.
Right. So it's kind of yeah, I mean, I guess that could be a behavior. I think it's a different kind of involuntary sort of it's an involuntary sort type of response, type of behavior.
So it's
Right,
not
that's a react.
consistent with your
That's more
definition.
of a reaction, right? Like a real like an automatic reaction. You know what I
So
mean?
the
But
behavior
I don't want to get
reaction-
down that
Sorry.
actually is going to bring us down a rabbit
Yeah,
hole that's
it
probably
actually,
irrelevant to the conversation. So I don't want to spend too
yeah,
much time on that.
true. What
Mhm.
was useful is to know that it's not part of your definition here. So
Mhm.
that puts us on the same page. So thank you.
Okay. Yeah, absolutely. So anybody on the call here know who Dr. James Gross is, a professor at Stanford University in the Department of Psychology? If you have not heard of him, so he is one of my heroes. And he wrote and edited this book, Handbook of Emotion Regulation, and this is my Bible. And yes, it actually is sitting seriously right here on my desk. And so I'm not joking when I say it's my Bible, and it's got like the tabs on it and stuff. And I got this book years ago, probably 2011 or something like that, because when I first, within a year or so of getting to Indiana University, and my goal and desire of understanding problems with emotion dysregulation after brain injury. And I figured, hey, well, let's start with understanding just how emotion regulation works in general. And then I can go from there to kind of understand what might be the breakdown after brain injury. And so I've been looking to him ever since, and that's his work is largely what models what where this work has come from.
Does he get into brain injury then?
A little bit. So we're going to be collaborating with him, and you'll see in a second, he co-authored an article with somebody that's interested in brain injury. So he is interested in it. It's just not the the typical population that he works with, or that he doesn't have expertise in it. So he needs and he's interested in collaborating with people who do know. But way back when, he had created a model of how emotions are generated. And this model essentially says that, you know, a situation, as I was talking about before, emotions arise from a situation that either can be internal, from our own internal pain, headache, whatever it might be, our own thoughts, or something externally in the environment, which then leads to us paying some attention, right? I mean, our environment's filled with lots of things, and we need to determine what we are paying attention to and what we aren't. And then we will appraise something. So we basically will judge whatever that something about that situation. So that's the appraisal that we have, our judgment, our evaluation of it. And then this will lead to a response, which that response is both an emotional response, a change in our emotional state, a change in our physiological changes, and then a behavioral response. So this is kind of that generation of emotional response. There's some debate as to, you know, do some of these things also happen before you do this appraisal or not? But the point being is these things play a role in generating this emotional response. What is important about this is that he then created what's called the process model of emotion regulation. So this line A here, as you can see, this continuum of what we just talked about: situation, attention, appraisal, response. He basically said that we have opportunities, according to B, that we have these opportunities to regulate our emotional response either prior to the event, so an antecedent focused emotion regulation, so we could modify the situation. If we know that we don't like noise or crowded places, you don't go to a busy mall, you pick a smaller store, you pick a time that's less crowded. We can, plan on and modify what we pay attention to. And then we could also change how we evaluate or appraise something. Or you can modify your emotional response after it happens as well. So these are all opportunities for us to regulate our emotions, either before or after it occurs. So I thought that was brilliant. I was like, oh, okay, well, this makes a lot of sense. It's extremely logical and makes a ton of sense. Probably every psychologist in the world knows about this, and it's nothing hugely groundbreaking. But if you think about, well, how can I apply this, right? So like I said before, so Dr. Gross wound up co-authoring a paper with Dr. Christian Salas and another co-author, Dr. Turnbull, on using this process model to understand emotion regulation changes after brain injury. And this was published in 2019 in Psychology and Neuroscience. And I was like, oh, okay, this is exactly what I've been trying to do for years, but without really making it explicit. But when you think about it, so what I wound up doing with this is taking his model and saying, okay, well, what do we know in general? Because my big area of interest when I got into this research was really understanding anger and aggression in people with traumatic brain injury, because it is so common and it can be so debilitating, and it's often chronic, and it's really difficult to treat. So I was just like, okay, well, what do we know about generally? What are things that contribute to people in general, people's anger and aggression? And when I started looking at this literature on appraisal and anger and aggression, I wound up coming across the negative attribution literature. So Dan talked a little bit about it before, but what is a negative attribution? So essentially it's our evaluation, our appraisal of other people's actions. So for instance here, right? So imagine you're at a restaurant, a really nice restaurant, you're with a date, and you're all dressed up, you just bought this outfit, and a waiter comes along and spills 2 glasses of red wine all over you. Whether we're conscious about it or not, we go through this evaluation, this appraisal of whether or not this person was that waiter's actions intentional or not? Were they hostile? Were they trying to be aggressive or mean? And how much do we blame that waiter for what happened? Did this person intentionally do this, or was there maybe a wet, greasy spot on the floor and this was completely out of the waiter's control? and there was no intention or hostility, and it was somebody else to blame because of the wet spot. So what we know about negative attributions, that there is this attribution emotion association, and that these attributions that we make about people's behaviors are strongly associated with an emotional response, and with specifically with negative attributions of intent, hostility, and blame, these are strongly associated with anger responses. And there's a ton of research about this in people without traumatic brain injury. And it's totally normal and makes sense. Anger is a normal emotion, and it's going to happen. If somebody did something to you intentional with, hostile intentions, you're going to be angry. That makes total sense. It is when there is a bias in how people interpret people's situations. There's a tendency for some people to misinterpret the situation, to have an evaluation of people's actions that are disproportionate to the situation. So where most people might give the waiter the benefit of the doubt, other people, there's this wiring, there's the way that a thought process, the cognitive, cognition, social cognition, things of that nature that are going to cause somebody to be more wired to assume, to jump to this person did this on purpose and have a more negative interpretation. And so, whereas most people, when you're raised, you're taught to give people the benefit of the doubt. So people who have negative attribution bias more often, even in the general population, struggle, have more difficulty. There's more, they have lower performance when it comes to cognition and executive functioning, as well as their ability to make social inferences. So
I still questions at that point.
Yeah.
So is there other issues with almost like response to anger and response to perhaps a back history that leads them to have that conclusion in that particular type of situation?
So you're saying, are there maybe historical events that can contribute to somebody to be more biased to perceive?
Yeah, and I guess,
Yes.
and the funny thing is, I'm taking your images that you did before, and I'm supplanting my brain injury experiences on that to try to explain it, but only for me. So I don't want to. I guess I'm projecting that to the non-brain injured. I don't know if that exists or not.
No, it does, and I think it's called, and I could be wrong because I am not a psychologist. I always want to alert people I'm not a psychologist. I have a degree, a master's degree in cognitive psychology and a PhD in rehabilitation science. But I think generally what you're talking about is like schemas and people's historical. So there are, right, if you are if you're in situations where, things happen that tend to work out for the worst,
Yeah.
or even, I want to think about like a totally different culture. Like you think about the military culture, right? Where everything is a threat and you have to interpret everything as a threat. Yeah, you're going to be more likely to assume negative intentions, right?
Right.
So, but then adding a brain injury on top of it and having difficulty with kind of the cognitive things that you need to work through and hold in your working memory to think about all of the pieces of a situation, to think through kind of why something might have happened and imagine what it might be like to be in somebody else's shoes. Maybe you may be less inclined to do that or less primed to do that.
And I would add the thing that I keep thinking about as I observe this in me is that it's always with the realms of what I had lost and slowly regained in terms of mental map and memory and cognitive aspects and interaction with other people. So I have I'm very sensitive to those issues because that's the core problems I had with my brain injury. And so that's why I think it connects directly with that. And so the model then kind of would need to add that for brain injury because some people may have injured some specific capacities, but others are totally fine. But it's those specific capacities that are injured that we create this bias with.
Right. I think it just makes their more risk, that there's an increased proneness or tendency.
But you have a history with it, which is why it's so
Mhm.
sensitive. Yeah.
Yes,
so-
right. And so, yeah, and I think that comes, when you think about situation, internal, external, like your history, those thoughts, your personal experiences, that's kind of your internal. You bring that to every situation, what you have internally of your personal experiences and stuff that play a role.
That
Hopefully.
sense of retraining yourself is what you're saying. And I had to retrain myself as a child, as an 18-year-old kid, and retraining, and then had to learn throughout life in that brain injured, learning how to read and such, and looking like a normal person throughout this entire thing, and having to, get a job and learning how to high school and all that stuff. So processing and trying not to be an angry person, and learning how to use that anger, how to not be angry. When you are angry, remembering the anger is part of your retraining and learning how to not be angry. When
Right.
anger comes, learn how to realize that anger is part of your head injury.
Mhm.
And that try not to get arrested, because I was arrested. I was arrested in San Francisco alone. My family was elsewhere.
Mhm.
You gotta, and I learned hard from that.
Right. Right. And I think you're exactly right. It is this relearning. And I think it's also being aware of what causes your anger. I think so. Every person with a brain injury is different. And I guess it's important for me to say, when I have more time, I start this off with even more background. It's like anger is very common after brain injury, but it's also because of the heterogeneity and how different every person with a brain injury is. What might be causing anger in one individual with a brain injury might not be the same thing that's causing anger in another person with a brain injury. The anger itself might look the same, but the underlying causes may differ. And
Sure,
what
but
I'm
there's an
saying,
aggression level that's raised up. I actually invited a scientist that studies this, but I never heard back from her because there's so many things that are off, that there's this baseline of aggression that's increased. And I think although the particulars are different, that seems to be similar across most brain injured people.
the anger and the aggression can be, but understanding why an individual does have it. And so what we're saying here is we're looking at this could be one piece. This was my question. Are negative attributions, is this way of thinking something that is common in people with brain injury and likely to be causing an issue for some people, not everybody, but for some people? And if you can I self-identify this as a problem for yourself, that increased awareness potentially to think, how can I change the way I think about this? How can I, so to prevent it or quickly notice it, so it becomes a red flag, and be like, okay, I need to change the way I'm thinking before I do something that's going to get me arrested or that's going to get me in trouble. I see, Nancy, you have your hand raised.
Yeah, this might be a good time to interject that sometimes the perception of anger is attributed to the brain injured person, but misunderstood. And so you might want to choose to address that later, because it seems like it's quite the opposite of your presentation today. However, it's a very valid concern in my life.
I think I know what you're saying, and I don't know how much I'll be. So people think that a person with a brain injury, that they're angry,
when in fact they're struggling to
They're
be
not.
understood or heard,
Uh-huh.
but they're
Mhm.
not actually angry.
Okay. Yeah, we can, yeah. Okay, yeah, that could be something we might get to a little bit later, and I don't know how, if I can address it specifically, because it's not something I study exactly, but it is an interesting concept.
I've gotten that a lot as well.
Mhm.
That I've been told that, I sound angry, and I'm like, I'm not angry.
Well, that's the interest. Well, okay. All right. So you
There's
ran
a
into
whole
this
other
okay.
layer
So,
there,
well, to me, there's a whole nother layer there. And I would tell you to go back to the alexithymia presentation that I gave you. And the
Matter of
thing
fact,
is,
when you were talking,
you're-
that's exactly what I thought
if
about,
you're-
was how alexithymia comes into play
Yeah,
with all of this.
that's a really interesting question. And I don't know the exact answer of that, other than people with alexithymia have more difficulty with this, because if you
Yeah.
have alexithymia, you're going to be less aware. And how do you then make that conscious effort to think differently if you don't know. So
Right.
and this is me as a non-brain injured person saying this, that if you are well, I know when people don't understand me, that frustrates me, that gets me angry, and then I start raising my voice, I start getting irritated, and I start getting abrupt and kind of snarky. And so ultimately I am getting angry because somebody didn't understand me, but it's possible that maybe you don't think you're angry, but I would actually question whether or not you're truly angry and feeling other emotions that are making your behaviors come across to others that you're angry because you're frustrated, you're not being understood.
And then you throw alexithymia into what you just said,
Right,
and
that
you
you
got
might
one
not.
hell of a mess on your hands.
Right. Exactly. Yeah. There is and I'm sure they kind of
Yeah.
all intersect. So yeah, interesting questions though. I think all good. This group is fun to talk to because they're such robust discussions. So anyway, so negative attribution bias, again, this is all stuff that's been looked at in people without brain injury, but then became my goal in life to understand what are negative attributions like in a person with brain injury. So if we look at people with brain injury, do you still see this common link that how, thinking somebody's actions are intentional or hostile, is that associated with feelings of anger and aggression? Are people with TBI more prone to these negative attributions, having this negative attribution bias because of some of the likely because of the cognitive challenges, the difficulties with reading social inferencing and perspective taking? And if they are more prone, what might put somebody with a TBI at risk for being more prone? And then 4, if this is all the case, is this something, can we minimize and reduce a person with brain injuries, the negative attributions that they make, and thereby reduce their anger, aggression, and overall emotion dysregulation? And so we use them. There's a couple different measures that we use, but just to give you an idea, when we do this in the lab and we bring somebody in, we evaluate negative attributions with these hypothetical scenarios. And there's a couple different measures. This is one that I use more frequently. And there's 21 scenarios and they're written out. But we also kind of read them, and they're short. They're about not short, but they're about 4 or 5 sentences long. And a third of them describe situations where a person has very benign actions, are very clearly benign, but it leads to an unpleasant outcome, hypothetically, for you as the reader. Or you have a story where it describes actions of a person and the actions are very clearly hostile and it leads to unpleasant outcomes for you. And then there's a third of them that are right in the middle, and Dan mentioned this at the beginning, that describe these behaviors that are they're ambiguous. It's really hard to tell if this person was doing this on purpose or not, but ultimately the actions regardless led to a negative outcome for you. So at the end of reading these short paragraphs, people are asked to rate how angry they would be in response to the situation, how intentional they felt that the person's behaviors were, how hostile, and how much they blamed them for the outcome. We later on added an additional question based on a different measure, asking what would you do in response to this situation? So an open-ended response, and it's scored for the level of aggressiveness of the behavior. And ultimately, so we then proceeded with answering those questions, the research questions I had. So I'm not going to show you all the data. I can give you the publication, I can tell you the response, but ultimately we conducted this study in people with traumatic brain injury and found that the more intentional, the more hostile, the more blame they interpreted of the person's behavior, the stronger their anger responses were. So yes, this association between negative attributions and an anger response exists in people with TBI, just like it does in people without brain injury. So, but the next thing we did was we looked at aggression. and like I said, this was a different measure. This is the other measure that actually does have an open-ended response about aggression and behavioral, and there's procedures for evaluating that open-ended response. And we found out, yes, people responded with more aggressive behavioral responses. Like I would follow somebody down the highway if they were tailgating me, and I would then, follow them into a parking lot and take out my knife. Like people would give really aggressive responses to certain behaviors. So we saw that association. The next question we had was, do people with TBI, what are their evaluations of people's behaviors compared to people without brain injury? Are they more extreme? Are they more disproportionate to the situation? And what we wound up finding out is that people with TBI always, regardless if the behavior was benign, ambiguous, or hostile, they always, on average, I should say, the average group response for the people with brain injury was always more extreme, thinking that it was more intentional, more hostile, and more blame-worthy. We then looked at, so then we said, okay, well, this is an association in people with brain injury, this negative attribution with anger. We found out that it's more frequent in people with brain injury than people without brain injury. And then we wound up finding out what are the risk factors. So what might make somebody more likely to have these negative attributions? And one of the things we found was somebody's trait aggression. So their tendencies, more of a personality characters of their tendencies towards aggression, which is no surprise. That's not shocking at all. We also found that lower social inferencing skills, so how they performed on a test of social inferencing.
What does that mean? Social
So thank you for asking that question. So if I'm going to ask, so like you and I are interacting and I want my ability to infer, what are you thinking? What are you feeling? What are your intentions? Kind of, what are your wants, beliefs, desires? So my ability to understand what do you mean without you verbally telling me what you mean. So basically using nonverbal cues or context for me to say, if I made you dinner and you said, "Oh, Dawn, thanks for dinner," as you threw half of your dinner out in the garbage, I might be able to infer that you didn't really, if you said thanks for dinner, it was great, I might infer that you were being sarcastic and that you didn't really like my dinner. So it's
maybe I was just being nice.
Maybe you were being nice and you didn't want to hurt my feelings, but then you shouldn't have shown me that you were throwing my dinner out. But point being is, like, I'm making inferences about your thoughts, your feelings, your wants, beliefs. There's a whole lot of things, the information in the social world that we are not explicitly told that we have to make these inferences about, right? Like if you see somebody, come up to you and, they're in shorts and a t-shirt and they're all sweating, you might make an inference. Well, this person just came back from jogging, or, you know what I mean? Versus if you see somebody come up to you and they're all sweating and huffing and puffing, but they're in a business suit, well, maybe they're being chased by somebody. You know what I mean? Like you make these inferences without having all of that information.
Is there a difference between the social whatever that word is, inferencing and the ability or inability, or I should say, let me request, or any deficits in picking up on social cues?
Oh yeah, social cues are the same thing. Like, so
Okay.
social cues, like our facial expressions, fall into part of social inferencing. So being able to that those social cues of like, yeah, you're standing too close to me, or yeah, this person needs to go, like they're looking at their watch, or that type of stuff. So yes, all those social cues fall into that. Another term that's frequently used is theory of mind. So whenever we're interacting with other people, we try to create a theory. We create a theory in our head about what is it that they're thinking, where might they be coming from. So yeah, so people who have a harder time making accurate inferences about other people, what they're thinking, what they're feeling, are going to be more likely to make negative assumptions, judge other people's behavior negatively, even though it was not intentional.
But isn't that a function, isn't that just a function of your survival state, if you will? A function of protecting yourself?
I don't necessarily know. I think that depends on your background and who you are and how you grew up and your culture and a lot of things. Because for me, if I assume at work that everybody is out to get me and is always doing something mean, intentionally mean, and this gets me angry and aggressive, that's not going to be a survival skill. It's going to get me fired. But if I am a war veteran, like if I am a war veteran and I'm out like interacting with potentially hostile people, then yeah, that's a survival skill to assume that people are out to hurt me.
But to add the TBI layer to that, which was I can only speak from my experiences, but the survivalness kicks in if I'm driving and I know I get lost all the time and I'm on edge when I'm driving anyway, and I have this whole history of slowly figuring out how to get to places. I'm in that agitated state when I'm driving, and then this can kick in much more easily versus when I'm sitting at home and the exact same situation presented itself. And so that's the TBI centric. I will use the term survival, but it's really more tension because of specific things in my brain injury history that is making me already at a 4 or 5 in terms of stress. So that's how I have interpreted it in myself. And then it's not a survival thing, it's a brain injury thing.
And potentially what I'm hearing too is there are things that might be more likely to make you anxious.
Right, but the anxiety presents itself in, like one of the other brain injury problems I had was with thinking. So I'm always thinking. So it's like that. Then what are you talking about? Then it's hard to explain. But when I see that I had a negative attribution and I can trace back why, and then I say, oh, it's because I was anxious. But the that's where the brain injury does to you, because it's like maybe not everything is not working and cognition may be slow or bad at times, but the problems you have with the brain injury just make the place where you're in that mental state more easy to be triggered and aggravated. And again, I'm only speaking from my experiences, but that's the stress that comes with it, and it's doesn't have to do with upbringing or being a war veteran, for example. That's
interesting. It's very interesting.
Was your injury were you awake when you realized your injury happened? Was it did you have any kind of like accident where you woke up and said, oh my God, what's happened to me? Or, I had an accident. I was in a coma. I woke up. I had no idea where I was. I needed to get out of this hospital. I escaped a couple times. I really wanted out. I had no idea that I had an injury. My instinct was to get out of this hospital. I did.
So that early stage of a brain injury is probably not where we're talking about with this, but obviously it would be
true.
In a state too. Yeah, because
the people in our study had to be at least 6 months after their injury. I think actually for the study it could have even been a year after their injury. So yeah, we're talking about like way after, not in the hospital or anything. That's another interesting time point to consider, just not when our research has been done. I'm just also looking at the time, so I want to kind of move on to just to make sure I can get through the slides and stuff. The last factor that we found that made somebody more likely to have negative attributions was Hispanic ethnicity. It was more attributions of hostility. People who of Hispanic ethnicity had more attributions of hostility.
Any idea why that is? Why would ethnicity have anything to do with it?
Yeah, well, I think that there's a lot to unpack and evaluate there that we don't know. I mean, there's definitely potential theories, but I think we were even talking about it's like, I don't know what is the culture like his, if you think about the time and people acceptance and belonging of people who are Hispanic, immigration, things of that nature, kind of tolerance, inclusion, racism, kind of
But-
thinking about
You could apply that to lots of, almost any ethnic group.
well, we basically would Hispanic or not Hispanic as ethnicity. For race, we probably had less variability in our sample. So unfortunately, I mean, this is 120 people. So you're right, like you probably can, and it is probably there. And depending on environments where people grew up and where they live, financial situations, there's so many different things. But like I said, I think there's a lot more to be explored there. We just need larger samples, larger and more diverse samples to understand it.
Just for clarity, it's Hispanic ethnicity with brain injury, not
Yes,
just.
sorry,
yeah,
correct,
yeah.
yes.
No, that, yeah.
Well,
that
that's everything, yes, exactly. All of this is for people with TBI specifically. Yeah. Yeah, so that's what we found. So then basically what we did was we a very creative colleague and friend of mine created an intervention to help people with brain injury be less, to help reduce these negative attributions and hopefully teach them to be more benign in their interpretations of other people's behaviors. She created this intervention over in England. She is a neuropsychologist by trade and created this alongside a speech language pathologist. And the two of them co-led just a 2-person case study group, which led to some positive findings that their intervention, which ultimately focused on, and I'll tell you in a little bit what the exercises were, but the exercises were designed to help people with brain injury be more effectively take other people's perspectives to give them the benefit of the doubt. We then, and their intervention that they created helped these 2 individuals significantly reduce anger and aggression. And I'm talking about like 20 years after a brain injury. They had 6 sessions using this strategy and had really substantial changes in their anger and aggression. So that led us to do a larger study, which was funded by NIH, and we changed the name of the intervention to Intervention to Change Attributions That Are Negative, otherwise known as ICANN. And we created this and we did a feasibility study with this. And our objectives were to see through this feasibility study if ICANN was able to help people with brain injury have less negative attributions about other people's behavior, to see if they were better at perspective taking and social inferencing, and if they were if they had reductions in their overall anger, aggression, and then I didn't put it here, but emotion dysregulation. What we wound up, so this was our this is our participant population. So people were on average in their early 40s. The predominant 70% were male. We had only 1 person in the study who was Hispanic, predominantly white. And then we also had, so everybody in this study they were predominantly more moderate to severe traumatic brain injury. And on average, they were 13 years post-injury in this study. And there were 24 people that went through the study. We had 20, and 3 people did drop out. So we have data on 21 people. As far as the results go, when we looked at their changes in attribution, so this is attributions of intent, hostility, and blame. The smiley face is indicating that we saw significant reductions in their negative attributions of intent and blame. We didn't see a significant change in hostility, although it was trending in that direction.
You didn't make any distinction between men and women in that, did you?
We did, no, we
It
did
would be
not.
interesting. I wonder if it's more predominant with men than it is with women.
In our initial study of risk factors, sex was not a risk factor. So it's kind of interesting.
Okay.
But to determine who is more likely to make these changes. I don't know. As far as perspective taking goes, what I'm going to say is we had two measures of perspective taking. One was like a standardized measure, and we didn't see any changes on that. The other one was another measure, and I'll show you that in a second, and that'll give you more insight there. The other things that we looked at was their anger and aggression. So we looked at their anger in response to these hypothetical scenarios, their aggression in response to hypothetical scenarios. We used a standardized measure with the promise outcome measures for anger. We used another standardized questionnaire for aggression. And we saw significant reductions all the way down the line here. So mind you, and this was 6 sessions of an intervention. So it's really kind of exciting to see in people who were an average of 13 years post-injury.
Is there a name to the intervention that that woman designed?
Yeah, it's called we wound up calling it ICANN, the intervention to
Oh.
change attributions that are negative.
Okay.
And let's see. So we also asked people globally, like, did you think since starting the study, was there a change in your perspective taking? And then they could respond anywhere on the scale from 1 to 7. And what I think of as a success is at least getting to a 5, saying that you felt that you feel moderately better and a slight but noticeable change. As long as there was some level of noticeable change in your behavior, I think that that's a win.
Did you ask the people about the nature of the change internally, or is that kind of too hard?
They felt the perspective, well, I don't necessarily know that I'm going to answer your question, but give me a second and I'll get to the slide, and it may or may not answer your question. But we had 83% of the people felt that there was a noticeable change. Then we asked the same thing just for anger and aggression. And we found that 45% found that there was a noticeable change in their own anger and aggression based on this measure. And then lastly, we use this measure, it's called the DERS, it's difficulty and emotion regulation scale. And we looked at their pre-treatment scores. So higher is worse because it's dysregulation, not regulation. So higher scores are worse, you want them lower. And their post-treatment scores. And there is a significant reduction in their dysregulation as well. We then asked, I don't know if this is getting at your question, what changes have you noticed in yourself? So these are some of the answers that we saw qualitatively from people. I think more before I say something or before I volunteer. Notice sometimes in certain situations and certain topics that trigger frustration, I've been able to employ the ICANN strategy, more understanding of people. I don't jump to conclusions, think more logically. I'm more tolerable of others. I have a delay in my actions. I'm more aware of other people's perspectives, and I've improved on not just reacting solely on my first emotion. When I drive, I'm more calm. I see other people and give them the benefit of doubt and put myself in their shoes. So
Yeah, that's very much what I was asking. And I think that I want to say that these read the same thing, and then to find a way to quantify that, or at least have a discussion about that. Because it's like you add a little gear into yourself before, when the reaction happens, and then the consequence that would have been there. Maybe there's more thought or more consideration, whatever you're adding into them. I think that's really cool, and fitting brain injury changes over time, which are hard to do and take time and take like adding, perspective and I don't know, I guess emotional regulation in this case.
yeah, it does. And it sounds like it seems like they definitely started a delay between a thought process and a reaction, and kind of giving themselves time to rethink, to reset. Nancy, you have your hand raised.
These seem like really useful, practical tools. The question I have is similar to Daniel's, but with a different tact. In the surveys, meaning the evaluations or whatever your assessment tool was, in the ratings that were on the bars and one of your slides, those were completed by who?
The person with the brain
Or
injury.
the okay.
Yeah, because to us, it's very important subjectively. I mean, maybe other people, family members, that matters too, but we were just curious subjectively, do you notice a change in yourself?
Is that the
And
same as
all of them were, or just the bars that you showed, like who?
All of them, all of them.
Okay, thank you.
Yeah, all of them.
Dawn, is that the same as increasing empathy?
That's such a great question. Yeah, a lot of people use empathy as another way of saying that. So when I think of the term empathy, there's different components of empathy in terms of a cognitive aspect of empathy, of being able to think and understand and put yourself in somebody else's shoes and understand cognitively what somebody might be going through versus a shared emotional experience. But this kind of being able to stop, put yourself in somebody else's shoes, share their perspective is a component of empathy. So yes, that's
Okay.
exactly what this is.
Okay,
Mhm.
thanks.
Yeah. So I just want to go back and tie this back to this process of a process model of emotion regulation that was created by James Gross. Essentially what we're seeing here is if we with this appraisal piece, if we decrease thoughts of intention or interpretations of intention and blame about other people's behaviors, this in fact leads to decreases in anger, aggression, and overall emotion dysregulation in response to a situation.
I like that figure. Can you go back? Because I just can share from my experience. I think that the thing that I added to myself over the last many years is between the response and the appraisal, the response can be a reaction, and it's so triggered and so loaded and has all this like pressure behind it, but the pressure is brain injury centric stuff. The shift that you described, that what those people's wording said, suggests to me that you add the layer of appraisal being something either active or driven by empathy or whatever it is. Once that piece kicks in, then you can regulate more or not have the anger happen or recognize it in a certain way. And that's because I think that the reaction response is different than, oh, I'm answering trivia. It's
Right.
I think that, yeah.
And it's more intentional, that appraisal and how you appraise it, that judgment, it's very intentional. And I do want to comment on what you just said, right? So one of the things that people in the group said, it's not like the anger magically goes away, right? And in some cases, the anger is kind of justified because it could be, you could still get angry even if somebody didn't do something intentionally. But what it does is it can minimize or reduce the intensity of that anger and how you're able to kind of then function, right? So it's not
And
like in
not act
every
on the anger.
and not act on it,
Yeah,
right?
that's in the appraisal and more. It just doesn't lead the reaction to an overwhelming takeover.
And yeah, exactly, yeah. So I just thought I would give you a little bit of insight into what the intervention looks like a little bit. So what it is, as I was saying, it's a 6-session intervention. Each session is 2 hours long and was delivered once a week to a group of people by typically 2 facilitators. One was a neuropsychologist, one was a speech pathologist, typically. Every session, we started off with these I can core principles. I can put myself in someone else's shoes. I can change my perspective. I can change how I think about others' actions. I can change how I feel about others' actions. I can change how angry I get about others' actions, and I can change how I react to others' actions. So that was reviewed every week. We also started off the first session with a little bit about psychoeducation. What is anger? Anger after brain injury? What is perspective taking? How can perspective taking contribute to our emotional responses? And what are, appraisals? And then we would do why are you here? What was your impetus for being here? What are your goals? And then we would go into two exercises that happened every session. The first exercise was role play. We would show them a video that was similar to like one of those written hypothetical scenarios that I told you about. So it would show you an ambiguous behavior. And ultimately, then after watching the video, the individuals would have to individually brainstorm reasons for that person's behavior. And then the group would brainstorm together reasons for that person's behavior. And then together the group would kind of decide on what's the most benign reason for the action. And then we would role play that scenario, assuming that benign rationale, the benign reasoning. And I'm going to show just, I have a little video really quick of that. But then the other exercise that we do is this was all in person, and essentially everybody would come to the session with a personal experience that upset them, that they thought somebody did something that to wrong them and they were upset about it. And ultimately there would be 2 chairs, and we would get the person in chair 1. And they were in chair 1, they were themselves, and they would describe their thoughts and their feelings and what was going on inside of them during the situation. And then they would switch to chair 2, they would become the other person, and we would call them by the other person's name. Like, you know, if their name is Dan and they had something, they were upset at Randy, and be like, okay, you get in chair 2. Now, Randy, and it's really Dan, but you're saying, hey, Randy, how, you know, tell us how you thought and felt in this situation. And so they went back and forth from chair to chair, expressing their thoughts and feelings from that person's perspective. So it was very experiential in terms of what was going on, until there was a light bulb of like, oh, wait a second, this thought, this feeling, this is what contributed to this person's action. And it wasn't intentional. And now I understand why this person did this. And this had nothing to do about me. So I should give them more of the benefit of the doubt. It's very, very powerful. And we can't practice that. But what I could show you is this role play scenario. So this is Dr. Sam Backhouse, and at the Rehab Hospital of Indiana, and she was one of our clinicians. She was a co-investigator on this study, and she actually helped to create this video of a benign scenario. So listen to the video and think through, what does she mean by this? Why is she saying this? All right.
Hi, Dawn. I got you this coupon from Bed Bath & Beyond. I thought you could use it to redecorate your family room.
Were you guys able to hear that?
Yeah, my first thought was Bed Bath and Beyond's going into bankruptcy. So, that was my first thought.
I know, I saw that too. I just got that notification. All right. What? Tell me why, what's your thoughts when you see this? Why is she giving me this coupon?
Consider
Why
it.
did she offer this Bed Bath & Beyond coupon to me?
Their room needs to be fixed up.
Okay, my room needs to be fixed up. Does she think that, or do I think that?
Well, obviously she thinks it.
Someone wrote in the chat, she doesn't like my bathroom. It is ugly and needs changing.
Oh, that's Wendy. Wendy, you were able to join. Thank you.
My other one got canceled. Thanks.
Oh, thanks for joining. Yes, yeah. Sam thinks my bathroom is ugly. What else?
Just being nice.
She was being nice. Okay. How is that being nice?
Well, she didn't have to offer it.
So she's giving me a
She
coupon.
could
She
have
could
kept
have
it
used
for
herself.
herself. She could have given it to somebody else. Could have thrown it in the trash. I mean, you know.
Right, she was sharing something that she already had. And maybe even the person had complained about that room themselves. So the person was actually following up on a cue the other person had given, but
yeah.
they have a negative attribution bias to be insulted instead of,
Yes. Yeah. So maybe I told Sam earlier that I can't stand my living room and I really need to redo it. And so now she has this coupon and she's giving it to me.
Nancy doesn't have negative attribution bias, so she
No,
knows
exactly.
the answers. We don't know.
Well, what's really funny, like, I don't know, like everybody on this call, what your initial thought was, but I remember when she did this and I remember thinking, I'd probably be pissed. I
Why?
thought it was
Why-
my first inclination, because I have negative attribution bias. Because my first instinct is my feathers would probably be a little ruffled, like, oh, is she insulting me? This is like a a backhanded, gift,
She doesn't
whatever.
like your taste in
Right.
Yeah,
bathroom
she doesn't like my
decor.
taste. But no, but I think that if you go into this saying, you know what, I might have let it drop before, maybe you forgot mentioning it to her that it's been a really long time and you've been wanting to remodel and whatever, that she is going into this with good intention. This has nothing to do with her thinking my taste is bad, that I must have said something about it at one point and she's really genuinely trying to be nice. That will change how I respond of either being really snarky, or being like, oh wow, thanks, that really means a lot, I appreciate it. No, it's just going to
Yeah,
change how I respond to it.
Dawn, let me ask you something which just occurred to me. So the response that somebody could have, may be negative, and that response could be wholly and legitimately, just could be completely legitimate,
Yes.
as
Yes.
opposed to not legitimate, off color,
Yes.
whatever.
Mm-hmm.
Is there
Yes.
is there a, for lack of a better way of saying it, is there a line to be drawn between those two somehow?
Yeah, and I think it's a really valid question because, like I said, I think when I started this off, I said, if somebody really did do something with hostile intentions, there's every right to be angry.
Yeah, right.
Right. But I guess there's, it's interesting, right? I work with a colleague, he does virtual reality stuff with adolescents, with oh God, I forgot what disorder. Anyway, with adolescents with a disorder that leads them to be angry and aggressive. And in this virtual reality intervention, it's actually it's all in alignment with what we're doing here. And there's in the virtual reality scene, they're at in a school cafeteria, and the bell rings, and the goal is for the kid to get his tray of trash to the garbage can within 2 minutes so you get to class on time. But in one of the versions, as he's going to the trash can, a bully knocks off all of his trash off the tray so it falls on the floor. And there are these different perspectives that the participant can have. One perspective is to get a perspective of what the bully's life is in the morning. So yeah, that bully intentionally knocked off the stuff off of my tray, but you see in the morning that bully is going, has a terrible family life. He's being yelled at, being ridiculed by his parents, has just all of these awful things. And now, yeah, he shouldn't necessarily be taking it out on you, but you could sort of potentially think through, other people are going through their own things. Was it right? Am I still going to be mad that this bully knocked my stuff off? Yeah, but it still could temper how I react if you think that other people are going through things that could lead to their behavior.
I mean, that's a good empathy example, but I would answer Randy's question or Randy's statement with it's the bias part. It's the bias part when you keep leaning towards, oh, wait, that doesn't have to be my interpretation of it, and it causes issues with your family and friends. And
that's 100% right, and I'm glad
that,
you said that.
That's the biasy part.
That's part two. Yeah, you have to
yeah.
recognize when there's a bias. Are you always think through, am I really giving this person the benefit of the doubt? Is this
I don't
really
think it's a
bad
conscious bias.
No, but you have to
that's
make
the
it,
hard part.
you have to pull it into consciousness, make it
Right.
intentional.
And
That's
that's
a
the
lot
adding
easier
of
said than
layers.
done.
The issue is though, when they're brain injury problems, then the even gaining a mental space of what the issue is, because it's a brain injury thing that you wouldn't have had without the brain injury.
Yeah.
That layer needs to be there, and then adding what you just said, I forget the word, but the feature of now I can not be in the reaction. At least that's been that's how I look at it.
Yeah, and I think that switching of the chairs thing is a really, really powerful exercise, which we can't do. It does need to be led by somebody that really knows what they're doing. It has to be done in person, but that, it is really helpful. And I will say there are, people in our group who had a lot more cognitive challenges. Those people with more extreme cognitive challenges did have some difficulty with the group, but we were able to modify some of the exercises, and I still think there was some benefit. I am looking at the time, and I am going to have to go get my car out of the stupid pound soon. But before they close, and I don't have to pay another $150, and I can only pay 150 instead of 300.
Does
But
that piss you off?
you know, I am not happy. I gotta say, I'm not. But I'm. Yeah, I'm not
It's
happy.
not a biased attitude, is it? Yeah.
You know,
Yeah.
yeah, we can go
Don't
on about
forget
that. I do just want to show, this is a pull-out, or what's it called, like a sheet that's on brainline.org. You can actually print this sheet out. It was created based on this research, the power of the pause. You could think about the pause and the acronym. So P being put yourself in another person's shoes, ask yourself calmly why the other person did what they do. Were they really trying to harm you? Understand, thank you, Nancy, understand that there may be a cause for the other person's behavior that isn't related to you. See alternative and innocent reasons that might account for other person's behavior, and expect that most people are doing their best, and try to give them the benefit of the doubt. I think, you know, these take-home points, yeah, this is, you know, just be mindful and think through when you are interpreting other people's behavior and you're feeling angry, might this not be something that's contributing to that, and how you might be able to try to put yourself in somebody else's perspective.
Well, that example with the waiter that was in that pamphlet is a great example, but I think the brain injury situations are often different from that. And what you just said about this therapy is still being developed, and you need someone really experienced, just like the other alexithymia therapy. Like, I've had to go through 9 therapists to find somebody. She doesn't even know what alexithymia is, but she does accept that my interpretation is accurate, and that took several years to find somebody. So you're developing, you're in the, this needs to be made and then even put out there is the bigger problem. And so it's great that you are developing these, and it's good to hear about it. And it's like, I want to go to that, but okay, it's not available. It's still being developed. So
Yeah, I know, it's
Yeah.
that's really frustrating. It's so hard for me when people will contact me from, you know, all over and say, you know, a therapist in this area that does it, and I'm like, it's not really being done clinically yet. It is still being evaluated, and it's like, you want to be able to help everybody, but you don't, you know, at this point we still don't know everything about it. So, you know, we're trying, and, you know, like I said, I got this out there in Dublin, and people were excited about it. And I'm going to Australia in 2 days, and I'll be teaching them the alexithymia intervention and giving people the treatment manual. So hopefully it'll start to be adopted. And I
You're going
appreciate
to
you guys
Australia in two-
inviting
you're
me
You're going to Australia
here.
in 2 days?
Sunday. So maybe no, today's what,
Oh.
Thursday. So Sunday.
Have a
Yeah.
great trip.
Thank you. Yeah, it's a brain injury conference there. So I'm doing a keynote presentation, doing some of the stuff about James Gross and the emotion regulation theory, and then doing a whole workshop on our alexithymia intervention.
Do you
But I
happen to
appreciate-
know, is the approach from a public health standpoint of view, is the approach of dealing with TBI any different in other countries versus the US?
yes.
Yeah, yeah. Well, you know, insurance is one thing, and so it's in many other countries, it's easier, or there's longer term care, there's more access to care.
But what about therapeutically? Is there a difference in other countries, how they approach this versus what you might have in the US?
I think that there's more. I feel like I might be biased, but I feel like other countries have more focus on these social cognition. They're more in tune with it and do more to address it. But maybe, I don't know, maybe that's just my misperception. I don't know. But I
Okay.
think that because they have more time, right? When we have insurance that runs out after a period of time, and it's like you have to get to the most critical things, and then the insurance runs out, and then all this stuff is left behind, you know. Yeah, I'm not sure. It's harder to speak.
Okay.
That's just a feeling. I don't know.
Can you make me the host?
I did. You should
Thank
have
you.
accepted. Did
Thank
you
you.
accept it?
Am I supposed to accept it? I don't see an accept.
It says when I look at it now, it says host next to your name.
Great, I didn't see an accepting. Thank you.
Yeah.
Randy, to answer your question, I think other countries have drastically different resources, but I don't think they're implementing very different therapies, because like this example and the alexithymia, it's like it doesn't exist yet. And I think the first talk of this series I did with the brain injury, oh, what's the name? The National Academies of Sciences. I believe I trust their assessment, and I don't think that this stuff is even known about. And I've been seeing that over and over in the big talks that I've been going to. They're like, oh, we need 6-8 year studies now to even figure out what the problem is. So I don't think they have implemented it. But maybe individuals have, maybe people know, where the data is not there. One talk in a month is going to be exactly on that, and then next week we have the fatigue talk. So think we'll let you go, Dr. Newman.
Yeah, thank you.
So
Thanks
thank
for
you.
inviting
Yeah,
me. I
this
appreciate it.
was
Thank
really
you,
good.
Nancy. Thank you, everybody, for your attention. All right.
Good luck getting your car. Hope it all
Thank
goes
you.
well. Have a
Thank
great,
you, Randy.
safe trip to Australia.
Appreciate it,
Yeah, this
Randy.
was
That's a
very good.
long flight.
All right. Take care, guys.
All
Thank
right,
you.
take care, Dawn.
All right. Oh, good. Okay, last time she was the host and she left, and then the whole thing disappeared. Yeah, there's so much to talk about, right? Because it's like I think the points that we were making are not on her radar or enough.
You know, one of the things that I didn't hear her mention at all, and I suspect it probably was not included, and I'm not even, maybe this isn't very significant, is when they asked for people's responses about the ICANN therapy and, you know, what they came back with. It would have been interesting if they actually had these people wired up to measure their physiological responses.
Sure. I mean,
The
they
only
might
reason I'm
get
bringing
that
that
in the
up is because
future,
I'm in
yeah.
the midst of reading Bessel von der Kolk's book, The Body Keeps the Score.
Yes, Randy, I think that'd be really relevant. It
Yeah,
probably
I mean,
isn't the
you know,
scope of their research, but it would be something good to add to another
yeah,
seed planting for
Yeah.
future.
I mean, I
research.
would go the other way into the depth of what they're experiencing, because the feeling of gaining emotional regulation, the feeling of not having emotions take over, and the feelings of empathy, I think, are three very different things, and they're kind of grouping it all into one thing.
We're losing people attending. Does anyone who hasn't said anything want to share an opinion or a question?
Okay, I'll share something. So, I've noticed.
Who's
I've had
talking?
a
Ruth.
re-
Oh,
Ruth, I have
hi,
a re-
Ruth.
I have a re-injured concussion, and what I've noticed is that I have, less interest in being angry. I would be very confrontational years ago about issues that I didn't agree with. Now, it's like, I don't have the energy to get angry. That's, and it could be because I'm still feeling concussion symptoms. It's like, you have to have energy to get angry, and I really don't have the energy to get angry. I just kind of let things go. So it's just a different reaction.
I think that's really interesting, and I've met
That's also probably to your benefit, I'm sure.
yeah, I keep focusing on these capacities that change in us, but I've met, for everyone that I met that I'm like this, they're like I'm the opposite. And I think that it does have to do with some shift in the brain's,
Oh, definitely.
the circuitry underlying that. And then also you have other energy priorities and resources that you have to manage. But when that anger doesn't feel the way it did, and I've met multiple people now that have that, or like the emotions are gone. They're like, I say I'm like this, and like, well, I'm the opposite. So I think that it's all consistent with what can happen with brain injury, and that's probably to your benefit.
And I'm not so sure that's limited to just brain injury, because in von der Kolk's book, and I think Matei in his book talked about it as well, I think, was what they referred to as this numbness.
Randy, you
trauma
just
that
read
occurs.
those 3 books, and then you're like, well, I read these books, and now I can say, but I think the numbness is a completely separate issue. And I think
Separate
that
from what?
separate from feeling the emotional triggers either being there or not, feeling anger, feeling an emotional aspect that it can literally be. The numbing is something that you and I had talked about and had for years, but this, I believe Ruth is assessing what is in her, and when these people talk about it, they just don't feel the anger. They don't feel feeling the emotion of filling the blank of whatever emotion it is, but it's not a numbing. And numbing is a different thing. And numbing is a much
And
more
How would you
global.
distinguish, Dan, how would you would you distinguish between the numbing and alexithymia? Is there a I'm assuming there must be some distinction then.
The numbing is a product of alexithymia. The numbing is, I think, a characteristic of it. And again, if I guess I speak from my experiences because then I feel safe. I don't have to speak about, data or whatever the hell. But
Yeah.
I had the numbness for about 17 years, and then it hit me that I had no feelings, and then beginning to feel the feelings has been a huge process and very difficult to gain and build in myself. And Don Newman's alexithymia talk touched on that, and she has like spotlights on specific things, but the other things that I went through are not, they're not stuff that she talked about. So the gaining of the feeling, the ability to have it in you and not being overwhelming was really hard. And I think the numbing is more like I guess I want to say like a dissociation blanket, or like these levels of other things change inside you and they consume you so much that you don't even think about, or you don't even get into the feelings. And then once that went away enough, then the feeling started. And that, yeah, so the numbing is a trait of the alexithymia. Alexithymia is also just such a big term, it doesn't.
Numbing is broader than alexithymia, though, but in the context of the two topics around brain injury and your experience, yeah.
Well, but isn't there could be a numbing of, I just witnessed a massacre and I was in a war, and that leads to a certain numbing. And then with brain injury, the numbing that I had kicked in once I was home and once I was finally gaining awareness of what happened to me. And then when it hit, then I'm like, I need to shift this gear. So that I think is different. I have 2 or 3 interviews with people that, I don't know, it's a different numbing than the PTSD centric numbing, I think.
Boy.
Yeah, it's complicated. It just
Does Christina Coates or Leslie have anything to share or ask?
Well, they're both on mute.
yeah, they're probably doing stuff.
Very good
Anyway, you're welcome.
conversation. Thank you.
Hey, Chris. Anyway, yeah. So I think this was a good presentation. The other thing that Nancy and Randy both said about, you present yourself and then they think you're angry, but you're not angry, and then Don gives well, you maybe are angry, you just don't realize it. It doesn't solve the problem in any way, because that I told you I did some advocating for a guy, and the first thing we did at the doctor's office was go over that and have him sign paperwork. And they're like, you can't behave like that. And I'm like, this guy has PTSD from brain injury for 30 years or something. You can't ask him to sign a paper and not behave like that. And they're like, but you can't behave like that. And then we're like, okay, now can we actually get to the problems? It was very strange. I think it doesn't recognize aspects of the brain injury stuff.
I even experienced something like what you described, not with a contract, but I was traumatized just getting dental hygiene yesterday over similar circumstances.
Yeah, it's I guess
One whole
we'll go back and
conundrum.
watch this and then we can think about it. Maybe, Randy and I recorded a discussion and we got into the alexithymia lecture. I want to ask Don Newman if it's okay that we talk about it. I think it should be, but I think that these lectures, and then maybe we can record about it, because it's like there's other dimensions, other layers of problems that need to be addressed. So Ruth, you don't have this problem then, negative attribution bias.
No.
Yeah, that's nice.
No. It could also be age. As you age, I'm at 84, so I have a different view of life, I think. It's, certainly when you're younger, you're more emotional. And I think as you get older, you really start having a different view. I wouldn't argue about things, even if I don't agree with it, the way I used to argue about things.
Right.
Yeah. Much less.
Like it's just not worth the effort, so to speak.
the energy and you're not gonna come to any good conclusion and
Yeah, I guess that's the same. I guess that's sort of what I meant.
But-
Like not worth the effort.
you know, it's different as you get older, definitely different. It's, and better, I think, in some ways.
That's nice.
Your perspective is different.
So
Yeah.
next week we have a talk about fatigue and brain injury. And that guy's the only clinician that I've found that talks about this. He calls it the 75% rule, but it's basically the idea of learning where your limits are and then drawing a way to not get to your limits.
Is it on the same link and is it here? What time is it?
Same link next week at 11.
The one on the 25th of May. I don't have
What-
this in front of me.
What time, what day is that?
There's one on the 4th, and that is at 11. And there's one on the 25th, and that is at 10. All
The
these
one on the
people-
25th is on, what's the subject of it again?
So she is a cognitive rehabilitation specialist, and she's been observing this stages that the brain injury people who recover their cognition go through. And I asked her to speak very specifically about those stages. She had presented it as part of a bigger talk, and I had a long discussion with her about it. And it's like there's the fatigue, then the slow mental gears, and then the memory problems stages. And the thing I liked about her is that she says that, you know, nobody seems to be aware of this, and there's definitely no research about this, but I've been through it, and I know many people that it seems to be through. They might not even be the same stages, but just the fact that there's these such drastic stages with brain injury is where I'm trying to take that discussion. And so she'll be talking about that.
I just popped in the information you put in the email in the chat.
Thank you. Yeah, so that one's at 10 a.m. the 25th, and the other one's the 4th. Ruth, I think they'll have these at the Hilliard Center. I've been in email contact with the people there.
Next week it's at 11.
Yeah.
Yes.
But Nancy, the thing about his fatigue answer, I think it assumes tremendous support. And that's something that also needs to be discussed, because this guy is like not aware that, well, just don't do it. And it's like, but if you need to do it, then that doesn't exist. So that I think is funny. Sad funny, but anyway.